Welcome to Beneficial Conversations, where we will explore the world of employee benefits and dive into the trends, challenges, and innovations shaping our industry. Join us as we sit down with industry leaders, HR professionals, policy experts, and thought leaders to discuss strategies for creating impactful benefit programs that support employees and drive organizational success. So whether you're an employee, a consultant, or you're simply curious, Beneficial Conversations looks to provide valuable insights, actionable advice, and inspiring stories to help you navigate the future of work.
Welcome to Beneficial Conversations. My name is CJ Jordan. I am your host, and I have the pleasure today of being joined by Jeff Bak with Imagine360. Jeff, I appreciate you taking some time this morning.
Yeah, thank you for the invite. Great to be with you.
Well, before we hop into anything, the first question that I ask everybody that comes on here is I need to know about the best meal that you've had. It can be one that you've made at home, it can be one that you've gone out and had with friends, family, anything like that. I need to know about the best, most memorable meal you've had.
Well, it's a good question. I'd say last year was my 30th wedding anniversary with my lovely wife. We were in Nantucket. We went to a place called Crew. So commemorating, pretty good milestone. Also, the
Yep.
food was fantastic, atmosphere off the charts. So, yeah, that one was hard to top.
I mean, that sounds great. I mean, and now are you doing like seafood up there if you're up in Nantucket and all that?
Yeah, they have really good seafood, so everything is caught locally, and you get the cold water fish, which is great. I'm not as big a lobster guy as she is, so
Sure.
uh, but yeah, they have plenty of good stuff there. Great cocktails, really good, cool bar, good vibe. So yeah, it's got the whole package.
That sounds amazing. I desperately want to go up to that area. It is on my list of places to visit. So I love hearing that. Well, um, tell me a little bit about your background. I want to hear a little bit about your story as we, kind of navigate through this. So take me through kind of your coming up into this space and what got you to where you are now.
Yeah. So, for better or for worse, right? Graduated college, and my first job wound up being in healthcare, working for a TPA. And so
Okay.
you were kind of hooked from the start. Didn't know any better, but knew that you know this is a very complex industry. It changes a lot, and if you think about over the past 30 years, what we've done in healthcare, from the old indemnity plans with no networks to today's pretty complex environment. It's been a lot of change, been a lot of opportunity. And so, I was fortunate to work early in my career in sales and account management. You learn a lot when you're out there selling. When you can sell a product, the customer is always telling you and giving you clues as to what you could do to satisfy their needs. Doesn't mean you always can, but you learn a lot sitting in that seat, doing a lot of listening. And then when you have existing accounts, it's a lot about, are we articulating and delivering on the promise we originally sold? And
Mm-hmm.
are we reselling that client, right, every time we get together to say, your problem was this, we've solved that, and we're adding value, here. So it was a cool place to start as a young person, and I was fortunate to have an opportunity to buy the company that I originally started working with, 10 years or so after that period of time. And that was my first introduction to private equity. And private
Yep.
equity, I know, sometimes gets a bad rap,
It can. Yep.
for being aggressive and in their approach. But really, if you partner with the right PE firms, you'll find them to be really beneficial, right? That there's accountability there. There's a start and a stop, so that you're not thinking about it kind of as a family-run business. You're thinking about it as a business that, has some pace and has some cadence, and we have goals and objectives, and we're trying to, better the net improve the quality of the business so that
Yep.
ultimately you can appeal to more folks. So that started in 2000, and so for the past 25 plus years, I've been in the healthcare arena and PE driven organizations, and a lot in the third party administration, care management, network
Yep.
build out. And that's kind of what we're doing with Imagine 360 today. It's alternative health plan that has the full ecosystem of
Okay. Yep.
solutions for an employer that you can partner with.
Love it. And so, just for people who may not be familiar with the concept of alternative health plan, I want to make sure that we kind of describe that for some of them. You and I probably know it, obviously, but when you say alternative health plan, what does that kind of mean to you? What are you saying? What are you telling people?
So, if I think we're all familiar with the status quo, United, Cigna, Aetna, the Blues,
Yep.
and in the self-funded market, they like to offer, a package of solutions that come all integrated and bundled, and it's oftentimes hard to really understand from a transparency perspective what you're paying, what you're getting from what you're paying for, whether that's in the pharmacy arena or it's in the network configuration that they have or your claims data, all those things. And what an alternative health plan is trying to do is it's looking at each component part of that bundle and it's asking itself, can we do this in a more cost effective manner? And can we do it so that it's completely transparent and everybody knows what we're spending, what we're saving, who's getting paid what? And the ultimate objective is to lower costs of care. And typical, for us, a typical account, we can save upwards of 30% as to what you'd be spending in a broad panel PPO from a Blues United, Cigna, Aetna. And it's pretty consistent. It doesn't matter which one we're comparing to.
Right.
And at the core of our model is a lot of member experience, where we're trying to spend more time with members and employees versus less. One, so it's member engagement and really being a good listener and enabling all our solutions to show up at the right time in the right place.
Hmm.
It's a lot of education, because what we're selling is different. It's not going to have the Blues logo on it or the Aetna logo on the card, which is kind of easy to identify and easy to work with. But like a lot of
Yep.
things in life, right? Sometimes easy is expensive, and
That is correct.
sometimes, right? Sometimes having the easy button uh, can cost you a bit more. And so what we typically ask employers and employees, if we can educate you on how this works, if we can show you a path towards savings 30% or more and sustainability. So once we're at that 30% savings, we're going to see a 2 or 3 inflationary impact every year, not an 8, 9, or 10. What would you
Right.
do for that? Right? What would you be willing to trade for that? And more often than not, employers and employees and families just want to be shown how to go about doing it. So think about an independent third party administrator, right? That has your data and can share it with you and does all the transactions end to end. That's one. Think about some direct contracts in some markets where we pick one health system solution to contract with them directly at a rate that is substantially better than what you would get in a PPO broad panel
Yep.
framework. And then think about a cost containment strategy that if you don't go to that facility, we're going to control cost by using a reference point, which is Medicare plus 20 or cost plus 12. So you're fixing your out of area, out of network spend to a maximum amount of reimbursement. And then think about a pharmacy plan that's transparent, and you get all the rebates back to the employer, and there are no kind of hidden fees, and you're really looking to procure drugs at the lowest possible amount. And when you start adding all these things together, it becomes a meaningful amount of savings, and that's the whole idea behind this is healthcare is unsustainable. It's getting more expensive every single year. There's
Yep.
not a lot of alternatives out there. How many times have you heard, it's 10%, promise I'll get you down to 7% this year. Don't worry. Like, it's time to rip the band-aid off and say, listen, is there a better solution out there? And I need to see one. Not that they're like this, this is a bit of a spoon fed approach because you have a lot of clients that are in this arena. Listen, they want simplification,
Yep.
and it's already so complex. And if you start talking about making all these changes at once, it's too much to comprehend. And so
Yeah.
for the good consultants and good brokers, they come in with a pitch that says, I'm going to take you on a 3-year journey,
Yep.
and I'm going to show you how you can take back your health plan. And over the course of the next 3 years, I'm going to get you to a 30% savings, but we're going to do
Yep.
it in a measured way. And year one, I'll get you 10. Year two, I'll
Yep.
get you 10 more. And year three, we'll get the full 30. So it's almost like it's a health plan strategy that you bring in. And it starts by moving away from fully insured
Yep.
and getting into an ERISA framework, because you get the benefit of not having to pay extra taxes. If there's profitability in there, you're going to participate in that. You're not going to have state mandated benefits. So just getting out of that kind of mindset of easy button, fully insured. So, that's one. Two, you get to now deploy these tactics around direct contracting or reference
Yep.
based pricing or bundled reimbursement structures, those types of things. And then, pharmacy is such a low hanging fruit item, and it's just, there's a ton of margin in that for the big carriers, and getting that into a more transactional, transparent product is just a no brainer. And the disruption for doing that is modest at best. So there's a lot of things you can do. It's hard to do them all at once.
Yeah.
Sometimes it calls for that. If your client is like, we're we can't take it anymore, we have to do something very drastic. But more often than not, show me a path, give me some solutions that I can lean into here that can get me to those savings numbers.
I mean, there's so much to unpack from that. I mean, it was incredible. We could shut it down like at 10 minutes and, just call it a day, but there's so much to unpack from that. And one of the things is like, I mean, you mentioned, you're getting to that 30% savings and then, 2 to 3% moving forward, but like it's wild to think about that when we're in such a period of hyperinflation when it comes to, really health insurance. We're for the past couple of years, I think we've seen trend increases be 9 to 10% on average, and I think it's probably going to be the same around there. So when you contrast the hyperinflation compared to like what y'all are doing from your standpoint in your program, what is the hyperinflation doing to employers and employees, and what is your solution? How is that coming in to really offset some of that?
Yeah. So I think where you're seeing the pressure points with just the cost of care, is, the hospitalization costs probably account for about half of the total healthcare spend.
Yep.
And their inflationary costs, their charge masters, have more than doubled and in some cases tripled over the past 10 years. And so they continue to increase their costs somewhat unabated. And the mindset that's out there is, we're going to take their charge master and we're going to discount it by a percentage. It's just a bad place to start in terms of how
Yeah.
you're going to pay for care,
Yep.
because that number continues to increase and you're discounting something that has no relativity to value or actual cost. So if you
Yeah,
can
we
control,
hear, well, so and so has the best network discounts, and it's like, okay, but like discounts off of what? Like
right,
it's an arbitrary number. You're coming down from an arbitrary number. Like, why would you negotiate top down when you don't know what the top is? When you have the ability to negotiate bottom up, which is
that's right.
Medicare, which is the standard by which everything is based. I mean, I love what you're talking about. Like, it, that type of thinking is just like we need to get more people on that type of mindset of getting away from this idea of network discounts and kind of what you were talking about as far as like charge masters and stuff.
Yeah.
It just blows
I mean,
my mind.
charge master is just a fancy word for what's your actual cost to deliver the service.
Right.
And right, so you have these two benchmarks: Medicare, which is the largest payer in the U.S., and then you've got cost to charge. If you paid somebody 40% on average above, those two metrics, anybody on the planet would be happy with those types of margins, except for, hospital systems who want to try to make up for maybe some lost ground on Medicaid, and feel like it is logical to charge, somebody at age 64 who's getting a colonoscopy, who works for an employer, 5 times what they're paying in Medicare. Like, doesn't make, it's the same facility, it's the same doc, it's the same procedure, eh, but yet it's 5 times more expensive. So what we look at is just a no. That's just that, you're right. Let's not start up here and come down. Let's look at a reference point and come
Yep.
up from that. And we think 40% over Medicare on average is a pretty good place to be for reimbursement. And the beauty of it is, like, I look at our data, and when I started with Imagine 360 6 or 7 years ago, hospitals were accepting that mindset, that framework, that type of reimbursement, on average 85 to 86% of the time. And between, let's see, 2019 and 2025, that number has worked down to it. They now accept it 98.5% of the time.
Wow.
That's a lot of improvement. That's a lot of change. But what it tells me is it's a reasonable amount of reimbursement. We pay very quickly, and we educate once we pay it that this is a self-funded ERISA plan. They have a fiduciary responsibility to have fair and reasonable reimbursements, and,
Yep.
and in good conscience, we can't pay you more, or
Yeah.
else we would be doing the plan a disservice. And so it's not often we get a little bit of question around why we pay what we paid, and when that happens, we educate. Sometimes we have to pay a little bit more. Sometimes they get a little nasty and they want to pursue the member. And when that happens, it happens so infrequently that we
Yep.
have a lot of things at our disposal we can use. We can use our own capital just to reimburse them and move on. Sometimes we split it with the plan. Sometimes we just say we're going to use our defense posture and we're going to pay and defend what we reimbursed for until it's resolved, and that could take a little
Yep.
time, but that's on our
Sure.
nickel. And
Yeah.
it's a way we look at protecting the plan. But we start with the hospital, to your original question, which is the biggest driver, I think, of the increased costs. And the nice thing about when you do narrow networks or direct contracting, you're picking the best, or at least the one that's willing to play ball, and they're
Yep.
going to get their unfair share of utilization. And a broad panel
Yep.
PPO, you're guessing where your employees are going to show up, and you're not telling most aren't telling their employees, hey, this one has better quality, this one's a lot less expensive. All else being equal, you should go here, not here, because you're going to get better quality and lower cost. It's a crapshoot. So getting that focus on steerage to one facility versus all, and
Mm-hmm.
then using our kind of reference reimbursement philosophy on the ones you're not directly contracted with, puts together a really nice package, and it starts the savings flow towards your original question of, how do we beat back this inflationary pressure and what's different. That's a big piece, a very big piece of it. I'd say that maybe the number two item is, pharmacy benefits are now representing about a quarter of the total spend, and getting your arms around a transparent PBM that you
Yep.
could pay for by the script, where all the rebates are coming back to the plan, and the plan is the beneficiary of their own utilization. And then using importation. So if it's a repeat kind of 90-day type drug that you're on and it's a maintenance medication, they can import these drugs from Canada and some other
Mm-hmm.
foreign countries at a much lower cost.
Yep.
And then when there is a specialty drug need, hospital systems love to dispose those drugs in their own facility because
Yep.
they make a huge amount of margin on it, and it's very
Right.
expensive. And they talk about, the efficacy of doing it. Well, you can get that same drug in an outpatient setting at a fraction of the cost, and most people don't know that. And so being thoughtful about how you support the plan and being proactive and reaching out to the doc and then to the member and saying, did you know we can do this in a much easier, lower cost setting with all the same quality and efficacy things you'd want? And most people don't know that. And the savings are substantial. And it's those types of hand to hand combat items that if you do it well, you engage the employee, they know the cost benefit of making these changes. You're in a much better net position. And it's that same discipline that we then kind of take across everything we do: stop loss, um, member experience, medical case management, telehealth. I mean, all of our partners and vendors are screened for being, one, transparent, and two, the lowest cost we can possibly create to make all this come together in a low cost fashion.
No, that's incredible. And there's something that I've kind of heard from a couple of groups just here in the last month or so as we've been talking about, similar structures and programs to what you're, discussing here. And, one of the questions and concerns, and you've touched on it a little bit, but we're going to just expound on this specifically, is well, what about the people who have, like your cancers or your dialysis or something along those lines, where there seems to be a concern that in a model like what you're talking about with, a reference-based pricing model and alternative health, that these people may not necessarily get access to the same type of like coverage, or there's concern on how the people with those chronic conditions are going to get their treatment, or that something within that specific instance is going to be somehow different. Can you speak to like how it's probably not different, and it's all about how it's accessed from a financial standpoint, I guess?
Yeah. So there are acute cases, and cancer is a good example. Cancer oncology care. Um, we when members have those types of conditions, we typically try to find the best site of care, probably not local, but stateside, the best care we could find, whether it's going to be
Yep.
a Cleveland Clinic or a Mayo, and we reach out and we effectively say, what's it going to take to get this particular member in there? We think you guys have the best protocols for this type of care. And the good news is here is like, we'll probably get 10 to 20% off of their bill charges.
Mm-hmm.
But they're not as egregious, believe it or not, as maybe your local hospital is, because they have a lot of reps that they do in
Yep.
oncology, and they've got it down to a T. And the nice
Yep.
thing about going to a centers of excellence is you're going to get good care. The likelihood of having any type of relapse or kind of
Yep.
readmissions is lower. And the data that we've seen, their cost to charge ratio is pretty darn competitive. In other
Right.
words, like they're probably already not at 500% of Medicare. They're probably around 300% of Medicare in their normal way of delivering services. And so getting a 10% off of 300% of Medicare is a pretty good deal. I mean, that's not a bad place to access care, and the quality is excellent. So when we have those type of transplants, cancer, we try to find the best possible delivery system and the best possible care, and it's an area we think you should pay up, and that's not the time to be thinking ultimately about saving a ton of money. And that's exactly when you need your insurance, right? I mean, you're going through a stress event, you want to be supported. We give those types of members a quarterback that is going to direct their care from
Yep.
that point forward. And effectively, it's an RN that's all over the situation, that's going to be their care partner. And so we kind of lean in on those high costs and more difficult situations, because we're not trying to squeeze the last nickel right out of that. It's the colonoscopies, and it's the showing up at the ER because you had an injury or tweak something, and those are the costs that just get hammered
Yep.
without any type of management.
Yep. And so, I know y'all talk with a lot of groups in a lot of different areas. What do you find is the biggest misconception around alternative health plans from your standpoint? Kind of what you hear, what y'all discuss with groups about. What do you kind of hear on a regular basis?
Yeah, well, it's an easy one, because I was at the Health Rosetta function. They have their annual conference this week
Yep.
in Denver. It's the first one I attended, and people reminded me pretty quickly that we were scorched earth. Our predecessor company, ELAP, was kind of a pioneer in reference-based pricing, and their original model was just awesome, really novel. Uh, but there was not a settlement mindset. It was pay and defend, and
Okay.
that's what the company did well. And but there was really no blinking, and so they created, in some people's eyes, a bit of a scorched earth mentality, because there was no willingness to negotiate. There was no willingness to put our own capital to work to try to make some of
Sure.
those things go away. So the scorched earth mindset, and we've worked really hard to try to improve the member experience, the HR leaders experience, using our model. And a couple things that we've done, I think, have been, it hasn't given away the farm in terms of the savings, but it's mitigated a lot of the nuisance noise around the
Yep.
product. So as an example, we generally pay any type of a balance bill that would come up uh, below, $500 to $1,000. And there's a lot of them that are small dollar. Who wants to be annoyed by, right, a $250 collection at some point? So, like, there was a pretty easy cut point just to say, let's take care of those small dollar
Right.
nuisance items. And the fact that we never approached the system about negotiating something above 140 or 50% of Medicare. Oftentimes, if you offer 200 and you do it immediately, and you guarantee that the members out of pocket will be covered,
Yep.
they'll play ball. They don't have to go
Yep.
chase the employee for their out of pocket. They know that's being
Yep.
paid. And what's happened over the past couple of years as well is, like, now they publish cash pay rates, and those cash pay rates are typically lower than PPO rates. And
Yep.
so, without not having a network per se, oftentimes we can skate towards the cash rate. So there's a lot that we've done to make it more simplified. That's more on the back end. That's when somebody's been seen and services rendered, and now we're dealing with some of the other stuff that happens. But in a PPO product today, a broad panel PPO, the balance bill rate's around 2%. And how do you get a balance bill when you have a PPO number? How can that happen? Well, you go out of network, right? Who doesn't go
Yeah.
out of network on occasion? And when you go out of network, that falls on you as a consumer who doesn't know much about healthcare, not
Right.
somebody like us who does this for a living. And so what do most people do? They're nervous about their credit. They see it. They don't negotiate. They don't talk about what's a fair and reasonable reimbursement here. They just wind up paying it, or worse, going on a payment plan to pay it, if
Yep.
it's a high dollar item. And so what we think that's not a great outcome, but I don't think most members are talking about it because in our world, it's expected. We know it's going to happen. We want to be prepared for it. You've got full defense as an employee or a family. You'll never have to worry about paying any more than you're out of pocket.
Yeah.
Versus you get it and you're not quite sure what the heck to do with it, so you probably just pay it. And so that's a bit of a hidden problem. That's a bad guy in these broad panel PPO products. I think the other thing around the scorched earth comment is, well, nobody's going to let you in, right? Nobody's going to let you through the front door
Right.
because they're not going to. There's no logo on the card. It doesn't say
Yep.
blues, and it's just not true. The data points I can give you are 99+% of the claims that we handle. They're getting in to see the provider of their choice.
Yep.
Um, on that 1% that they're not, yeah, we do some work. Sometimes we negotiate what we call a single case agreement. So for that one individual at that one hospital who's saying no, what's it going to take to have this person come in? And
Yeah.
maybe we pay up to the PPO rates. Maybe that's what we have to do to get somebody in. But we get them in, and ultimately, care is rendered. They just, the thing is, I think people have a lot of pride, and healthcare is somewhat of a privilege, right? If you work, hey, listen, I work for this employer. I've got to pay a lot of money out of my paycheck to get this insurance, and with that amount of money that I'm spending, I'm kind of a little righteous. I don't want anybody telling me that I don't have bona fide health care, or tell me they don't recognize my logo, or tell me that somehow I've got this inferior product. They don't, but it might take a little education of that doctor's office to
Yeah.
say, here's what we reimburse. In fact, we probably pay the doctors a bit more than the average PPO pays, because the docs and the specialists, they're not the problem. They're
Right.
already pretty competitive. And so we don't need to fly spec those types of providers, because they're like 90% of the transactions, but only 10% of the cost. And
Mm-hmm.
so you could pay a little more than 10% of the cost to buy favor with those docs, because it's not where the money is. And so we try to pay, those types of providers very quickly, a little more than they normally would get. So what might happen on your first visit is they say, I don't recognize this. I don't see this logo. So just call us. And so when we
Yeah.
talk to the receptionist, we say, hey, we're going to pay you more probably than you're getting from the Blues United, Cigna, or Aetna, and it's bona fide coverage. Here's our TPA number. Here's how you submit the claim. Here's how much you're going to get paid for this visit. And they're like, oh. That's pretty good. And so they see the patient, we move on, and the next time they show up, they don't have the same issue. We're
Right.
now in the system per se. But if that experience to you is you know a problem, or you somehow feel like that's too much, it's a step too far, then an alternative health plan is probably not for you,
Right.
but nor is saving 30%. So, I mean, if you want to continue,
That's
right?
true.
Right. I mean,
Yeah.
like, so it's like, hey, listen, we all want to have a Mercedes, but some of us need to drive a Camry for a lot of reasons. And don't force me in a Mercedes if I can't afford one or don't want one in the first place. And that's kind of the way a lot of employers, there's a lot of Mercedes and high end vehicles being driven out there to a clientele that would probably feel just fine in a pickup truck.
Right. And I think it sounds like there's a perception that like the onus is on the employees or the insured to figure all this stuff out, whereas what you said, you can walk in and just be able to pick up the phone and call you and essentially say, here, hand your phone to the person and be like, they're going to get this squared away. Like, you're not, the employee insured is not the one that's having to negotiate, do all the negotiation and all that kind of stuff. It's your team that's handling any of that friction that might happen at the provider's office. Like, I feel
Yep.
like there's, like I said, just a perception out there that the employee is the one that's having to tackle a lot of these issues when it comes to explaining things and stuff like that, but it's really just not the case.
Yep. Yep.
And so you mentioned a little bit earlier, you were talking about, pharmacy. We know that that's, a massive, piece of the pie. And I know y'all recently launched, a pharmacy solution and an integrated, pharmacy and medical offering. Talk to me a little bit more about, what that is, what that looks like, how it's being used.
Yeah, so it's complete care and Imagine 360 RX. For a long time, we probably partner today with 70 different PBM groups, and we felt like having that as part of our package would be a nice differentiator. We are sourcing a lot of the solution through one of our sister companies called Livinity,
Mm-hmm.
that is a transparent PBM that's in the market today. We like the way they approach their service model. We like the way they approach their cost per script, and they launched something called Compass RX, and that's kind of an umbrella way to work with them, to work with members when they have specialty RX needs. And they do a really nice job of being able to source those and get different sites of care, as we talked about earlier. So it was kind of a no brainer for us as an extension of our current solution to bring that in. It's not mandatory. So if we can do something quicker, better, faster for an existing client at renewal, or for a new business, we'll do it. Or if it's something the plan or the broker or the consultant thinks they have a better mousetrap, fine. We'll work with whatever solution you have. But sometimes, and particularly as you go down market a bit, when you get, an employer with 150 or 200 employee lives, they like simplicity. They like kind of ease of use and packaging.
Right.
So we can offer that now on their behalf and do it at a below market cost. We're not trying to make the nice thing about us. I can say this with a straight face. We may be the only player in pharmacy who will lose a little bit of money on everybody who uses our pharmacy solution, because we felt so strongly about being on the right side of this that we did not want to have any economics in the pharmacy
Right.
solution, and be able to look people in the eye and say, we literally make no money on your pharmacy. We're doing this to help you kind of package and save as much money as you can. We get paid really well on the stuff we do, our core stuff, our RBP, our
Yeah.
TPA services. We don't have to make
Yeah.
additional dollars elsewhere. And that believe it or not, that message has resonated. Where you can stand behind the fact that you're doing this really for their benefit, not for any of ours.
Yeah, I mean, it's just alignment, right? I mean, you get there and you're able to explain, something like that. Like, I don't, I'm not trying to get you on this because I think there's an inherent mistrust that happens obviously in pharma and all that kind of stuff. So when you have the ability to say like, hey, this is not a revenue generator for us. This is just something that we want to bring to you because it provides value. It helps people, I that I can definitely understand how that makes sense and how that resonates, just because I feel like employers always think that somebody's just trying to get one over on them these days,
Yep.
which,
Yep.
unfortunately happens in a lot of cases. So obviously I'm in Alabama, and I want to kind of just talk a little bit about, Alabama is the elephant in the room. Blue Cross Blue Shield of Alabama is the elephant in the room. We hear so often, oh, well, I need them for recruiting and retention, or, they have the best network discounts and stuff like that. But I know y'all are doing some work here in Alabama. Would love to hear kind of some of the success that you're having here, and just helping people understand that you don't actually have to have Blue Cross Blue Shield, um, to have an effective health insurance and healthcare plan. So tell me a little bit about kind of what y'all are doing here in the States specifically.
Yeah. So, it's not our biggest market, and
Sure.
the Blue Cross presence is real, and they
Yep.
are the largest, most concentrated payer in the state by a big margin. We have we've got more than a couple clients
Right.
in Alabama. One is an anchor kind of reference for us. They're a manufacturing business. They're of substantial size. They've achieved that 30% savings that I was referencing earlier, and have not looked back. And it didn't happen all overnight.
Yep.
It was that kind of multiple year progression. But how do you? I mean, once you've gotten your employees familiar with the model, once we've been through 2 years, 3 years of utilization, having the conversations with the doctor's offices, knowing which hospitals in Alabama are going to be friendlier to reference based pricing versus the ones who are not, putting a plan design in place to reward employees to going to the
Yep.
one that accepts it. Same with the docs, getting enough education in those doctors' offices so every time they show up, they now know what we pay and they're delighted to
Yep.
take it. So was it easy in the first year? No, it was not. And we got a lot of pushback, and
Sure.
we had to kind of stand our ground. But like a lot of change management, it's never easy. But as you look back, and here's what it really took. It took conviction in the C-suite of this company to say we need a change. We have to start consuming health care differently. And by we, I mean our company,
Yep.
our executives, our
Yep.
frontliners, and everybody in middle management in between. We're in this together. This is a novel approach. There, it's going to be different, but we have a good partner that's got our back, and they're going to help us through this. And he pulled out his ID card and showed it, to me and said, "This is the same. This is real coverage. Anybody who can read or can engage or call will know that it's full coverage with all millions of dollars, right, of coverage, unlimited in most circumstances. It provides for physician care, hospital care, you name it. And so on that card, it's basically the same card you'd get from Blue Cross and Blue Shield, only it's without that logo,
Yep.
but it lines up and does the exact same thing. And so it's up to us as an executive team and HR team to educate our employees, to partner with Imagine 360, and to learn and work together because it's worth it. It's the little extra work is worth the 30% savings. And now we have something that's sustainable. The cool thing about what they did with the 30% savings is they reinvested it back into the plan. A
Love it.
lot of our clients will then take the single contribution and make it free.
Yep.
So, right, to promote people to use the plan, they're still going to ask for some cost sharing on the spouse and family. But for you as an employee, you no longer have a contribution to make. And that's like a raise. I mean, that was a tangible
For
benefit that this
sure.
group got for their employees, that now the employees are like, well, listen, there's no free lunch. If I get something for free, and you're telling me I'm going to save that contribution money, then what do I have to do? Like, what's my role in this? And so they're part of the play. They're part of the act. you have to do this when this happens. You have to call Imagine360 if you get a balanced bill. If your doctor's not familiar with your first visit, you have to call them. And, we put a QR code now on our ID cards so anybody can scan it and see what we're
Yeah.
going to reimburse them. So, yeah, I mean, it's been change is hard. We've had, our ups and downs, but I think net, you could talk to them tomorrow as a reference point, and they're delighted that they did it. They're still seeing the savings, and they've navigated through, some of the tougher parts of the model successfully. But I guess the bottom line is everything is solvable.
Hmm.
And when you have 95 to 97% of your payments being accepted at 140% of Medicare versus the market average of 300, and you're a substantial employer, you have some dry powder to play with.
Yep.
You've won, right? You've won
Yeah.
the game. Now it's a matter of how do we take care of these very small incidences that can happen, and do it in the most kind of strategic, cost-effective, and friendly manner for the plan and their employees. And if you do that, it'll work.
Yeah. I mean, I've been using the analogy, for people when kind of explaining this model, where I mean, you use the numbers exactly, 300% of Medicare versus 140%. It's like going to see a Taylor Swift concert at, wherever you want, Mercedes-Benz Stadium or something like that. It's the same performer at the same venue. You're just paying face value for the ticket as opposed to marked up costs on the secondary market and stuff. It's the same exact person and everything like that. You're just not paying these bloated fees, and that's what this model is. Instead of paying these 300%, you're coming down and you're paying this, and you're not having to sacrifice who you're going to see in this instance. It's just you're paying at a
Yeah,
much more affordable and understood rate.
yeah. I mean, our goal, the reason we exist as a company is we're supposed to be a fair and reasonable partner for a self-funded ERISA plan's fiduciary. And the way that ERISA laws are written, that if you're not paying fair and reasonable, then you're not holding up your end of the bargain, and you're doing your employees a disservice. And so, fighting for fairness, right? Trying to figure out how we get the lowest cost possible, um, is a main objective of ours. On the flip side, who wouldn't want to get paid 300% of Medicare? Of course they would. And so they love those PPO products to death because there's no contention, because they're getting overpaid for it. And by the way, when Blue Cross and Blue Shield is not in a fully insured product, when they're providing a self-funded solution, um, they have no skin in the game. They're not taking any
Yep.
risk, right? So they like it too because all they get is fee income. They get wonderful fee income. So it's like, and then the
And a
brokers get paid
substantial
really
fee at
well,
that.
for those products. So like the broker's kind of winning, the hospital system's kind of winning. Blue Cross Blue Shield is making nice fees without taking any risk. Who doesn't like that setup, right? The only person who's getting the raw end of the deal is the employer and the employees who are paying for a
Yep.
Mercedes when all they need is a Camry.
Yep. Yep. And so you've talked a lot about change management, and I think that's a huge piece just as far as what y'all do and how things are executed. And I heard somebody, or I read, heard, whatever, somebody posed this question, and I'm curious from y'all's experience across the board, not just in Alabama, but everywhere. Change management, is that something that you believe should be led from C-suite down? Are you trying to engage bottom up? Where have y'all seen the most success in terms of implementing this alternative health plan and seen it run best from a change management standpoint?
Yeah, every, HR team needs a playbook. And so it starts with HR, and we go to great lengths to help that HR leader know what they should expect to start doing 90 days in advance, right, of
Hmm.
renewal or going with us from the first time. Uh, the types of communications we want to do with the employees. We typically do go face to face with them to roll the plan out and answer questions. We put a benefits expert in each new account that we write every single year that's above, say, 100 lives.
Yep.
That will be their, kind of their partner, their surrogate. They're a good buffer with the employees. They've done this a million times with what we've historically done. And so they partner with the HR team so that, at least from an HR perspective, they're going to have their best chance of communicating the change management and making sure it sticks. Um, you know, the other kind of key factor is somebody in the C-suite has to be the promoting advocate of why they're doing this, and also convince the CFO that some of this money should go back to the employees, and depict exactly how and where and what that is, because the employee wants to know that if there's savings created and they're being asked to do something differently, then what's in it for them? And
Yep.
so being able to tie back to the specific employee, whether it's a contribution reduction, less out of pocket, lower copays, something that you can anchor off of. And when that happens, I think employees generally appreciate it and know that they have to also listen up, because there's going to be some different ways of going about consuming this product. Um, and then after that, right, it's a lot of reinforcement on the initial message. Most people don't pay attention in open enrollment, let's face it. So as you go through the first 90 days, there's a lot of firsts.
Yep.
And sometimes in our plan, a first is a bit different. And so we're prepared for and handle a lot of those inquiries on the first. But it generally, after the
Yep.
first 90 days, it kind of mitigates and we go forward. And a lot of it's around this provider doesn't recognize my ID card or the
Yep.
logo on it. So help me get through this. We do it once. We don't have to do it again, and we move on. So yeah, those are the big ones for us. I also think everybody setting a relative benchmark is important. So we also give the HR team some metrics, kind of what to expect the first 90, the second 90, the third 90, and then at renewal,
Yep.
on what a 500 life group would typically experience in terms of calls coming in, any type of confusion, us having to engage, getting your first balance bill, whatever it is.
Yep.
So we give them a bit of an anchor that they can to compare and contrast to, and it's proven to be very helpful.
And so, I know you mentioned the group earlier in Alabama, and you said, they just haven't looked back. With Alabama kind of being the market that it is, and just a lot of hesitation and comfort and stuff like that. What message? And again, again, I'm in Alabama, but there are other states that are similar to it. Mississippi is pretty similar, and I think maybe some Michigan and stuff like that. For those that have the strong, dominant Buka presence there, what are you wanting them to understand about this model? Like, what is it that you want them to hear and understand, and really just kind of take from this as far as what y'all do and how you do things better, differently, stuff like that?
Yeah, I think because of the conditions of those particular states and the dominance of the blues plan that you referenced, um, they want you to believe that it won't work and you shouldn't try it, and that somehow it's not worth the juice is not worth the squeeze. And I would say change is always hard. You have to start somewhere, and I would not use the fact that there's a blues dominant uh, plan as an excuse not to try. And hey, not every client, right, comes on our journey and stays forever.
Yep.
And so, right, you can always evolve and change, but I think it's just it's almost criminal not to try something different and start going down an alternative health plan solution type path and figure out what's right for your company and what's right for your employees. I think doing nothing and just being somewhat satisfied with 10 to 15% annual increases. A state like New Jersey, where we've got some brewing opportunities, for a family of four, and these are like for first responders, they're spending $58,000 a year for family coverage. That's what it costs in Jersey, and so that's what it
It's
could
not even
become.
insurance.
Yeah, I mean that's what it could become eventually. And that 58 grand of premium contributions is in a collective bargaining type environment. So it's money out of their pocket to go to healthcare versus going to retirement or going to salary. And so I don't know, like if you don't if you don't try something different, I think you're going to get the same results. And we could point to clients that we have in Michigan and Alabama and many other of these dominant blues and New Jersey. And I'm not going to say it's always easy, but
Right.
eventually it works. And if people are willing to work with us and partner with us, we think we can deliver the savings that they're after.
And this is, this is probably a toe stepping statement and people may not necessarily love it, but like, I mean, don't you think they kind of have a fiduciary responsibility to give it an honest look? And hey, if it doesn't make sense, it doesn't make sense. Like we're not saying force everybody into this model and like hear me when I say that, but when the numbers bear out that there's a better and different way to do it, that employees could receive better care and at a better rate, like when you're the fiduciary of the plan, you kind of have a responsibility to evaluate it and give it an honest look, don't you?
I think so. I mean, we haven't seen that type of litigation happen yet in ERISA. It's
Right.
happened in the 401k market. And a lot of pundits will say that there's a foreshadowing of what used to happen in 401ks and how that industry had to really tighten up the way they get paid and fees, and then shopping for best of class funds, all became very very regulated and improved quite a bit. The more they started to push on the fiduciary responsibility, of those plan sponsors, and I think healthcare is a little different, maybe not as easy to depict where you've been
Yep.
asleep at the switch, right, in terms of cost for funds. But boy, it sure seems like not having an alternative health plan option in your plan design makeup. We've been talking about all or nothing here, CJ, and we have a lot of clients who say, I'm going to keep Blue Cross and Blue Shield of Alabama, but I'm
Sure.
also going to bring in Imagine360 and offer it as a dual option and see what my employees are willing to choose. Because at least I can now look myself in the mirror and say, I am offering the Mercedes and the Camry, and now my employees can afford a
Yep.
car they can drive. Um, and so that's another way to think about it, which is it's not all or nothing, and you could experience savings, you could experience alternative health plan offerings while at the same time keeping employees who want to stick with the more expensive approach, they're not leaving it completely.
Sure. Well, last question that I kind of want to get your thoughts on. What are you, your team, everybody, what are y'all kind of keeping an eye on as far as, the next little bit, the next 3 to 5 years when it comes to healthcare? What is it that y'all are, trying to keep your eye on, finger on the pulse of?
Yeah, a couple things. So we really like data, and we have a lot of it. And I think using our data more smartly will ultimately show up in better site of care navigation. So even within
Yep.
reference-based pricing, right, there are certain hospitals that are potentially better quality at certain things, and you wonder if we can get smarter about which of those hospitals we want to get members to go utilize. So I think there's going to be more and more need for navigation to help somebody navigate through, whether it's a broad panel PPO, which is the best hospital in Birmingham. There's 4 or 5 of them. Why would they want to go to one that's 3 times the cost of the other? Doesn't make any sense. And helping members discern where they should go access care, I think, is a big one. Um, I think plan design is another one that will continue to evolve, but there's a lot of experimentation right now that hospital systems and docs hate chasing employees for their out of pockets. So if you took that
Yep.
burden off the table, um, and you gave employees a real benefit and a reward for following people's advice or following the steerage data, will they also comply? So it's kind of like the best of both worlds. You'll probably have a provider who's a little bit more willing to engage, and you'll have a member or an employee that's going to have a really strong economic benefit of going to facility A versus facility B, and they can feel the out of pocket impact. I think direct primary care, like just there's a lot going on in that arena,
Yep.
and as that model evolves and starts to, I think, shift to a more fee for a service or a smaller PEPM to access those primary care docs.
Sure.
Um, I think it's a really cool potential evolution in the business because we've gotten away from the family doctor mindset, but I think that family doctor mindset can be very beneficial for long-term cost control because you're using your health plan again. I mean, what's really kind of a bad guy about these high deductible plans, and even though if you have a lot of money in your HSA, you're not going to utilize because you're always on the hook for the first dollar. And some
Yep.
people don't have a big stockpile in their HSA, and so they're coming out of pocket for day-to-day utilization. That's tough if you start avoiding that. If you're not getting your annual physical, if you're
Yep.
if you're pushing things off because you can't afford it. And I think these direct primary care models give people an ability to use their plan again and be able to see a doc at no charge and re-engage in an appropriate kind of care delivery and preventative maintenance like you do with anything else. So I think those are two things that we're seeing in spades. And yeah, I mean, those are things that we're working on. I think the last thing for us is we're also in the stop loss market now. We have our own captive. We're being more aggressive on uh, being the stop loss provider on our kind of integrated solution from Imagine360, and we really like the risk profile as a risk taker of alternative health plans and reference based pricing. It's more predictable. There aren't when we uh, kind of take stop loss risk on reference based pricing versus a PPO product. We There aren't things in um, our contracts when we do a direct contract or kind of in the reference-based pricing framework that would say when you have an outlier claim, you're going to lose discounts. And there's a lot of that language in these broad panel PPO agreements. That's exactly when stop loss needs the most help. Complex
Yep.
case, high dollar, they're paying all the freight. And at that point in time, there are some PPO contracts that just say you're going to lose a portion of your discount because this is a complex scenario. We don't do that, and it's one of the reasons why we're having success from an underwriting perspective when the framework is reference-based pricing and direct contracts. So we're going to take more risk on the stuff. Kind of put your money where your mouth is, right? If you're willing
Yeah.
to promote it, you should be willing to take risk on it, and you should have some skin in the game. Like you should have guarantees out there, warranties out there. Sometimes, we'll put our fees at risk for savings, and if we don't meet the savings number, we get paid less or sometimes nothing. Likewise with stop loss, we'll put our money where our mouth is on stop loss. If you're a max cost buyer, which means you're being super conservative, you want to know what your potential maximum out of costs are for the plan. Sometimes we'll guarantee that you'll never hit your max cost. We'll buy it down from expected plus 20% to expected plus 5%, and
Yeah.
we'll be the risk taker in that corridor as a way to show that we have conviction that what we do works and it's going to save money. And so, I just think for us, completing the full circumference of solutions and being able to contain all of them under one umbrella, and more importantly, interrogate that each one of the things that we do is going to save money, and if it doesn't, why are we doing it? Yeah, those are the things we're going to be working on over the next few years.
No, I love it. I mean, and this was great. It's awesome to hear about, organizations like yours that are making a difference, not only in, for employers in terms of what they're able to save, 30%, which is not a small amount, but also for employees and being able to keep more money in their pocket from a premium standpoint, but also, what's coming out of their pocket, when they do have to access healthcare. So, this has been great. I appreciate your time. I know I learned a lot. But if somebody wants to, get in touch with you, find you, anything like that, where can they talk to Jeff or Imagine360, just to make sure that we, give people an easy way to get in touch with y'all?
Yeah, sure. I would welcome any and all feedback. And I talk to a lot of our clients and a lot of our producers and a lot of our employees. So you can reach me at any time at jbak at imagine360.com. we can go to our website and we have it kind of partitioned for if you're a member wanting to learn more, a producer
Yep.
wanting to learn more, an employer wanting to learn more. It's very intuitive, easy to follow. And so imagine360.com is another place to go. But yeah, those would be two areas of contact.
Well, Jeff, I appreciate it, man. Thank you so much for your time this morning. Again, thanks for the work that you're doing, and look forward to talking with you again soon.
Yeah, Jordan, CJ, thank you so much. Really appreciate the time here and a chance to tell the story. And even Alabama can improve, and would love a chance to work with some of your peers and yourself when the opportunity is right, and engage and do it together as a partnership.
Thank you. Appreciate it. Have a great one, Jeff.
See ya.